Hi, everyone. Welcome. I see Dr. Al is on, so that's great. And welcome to our medical providers update. I'm actually going to just let Dr. Al start and give us some very important information related to a non-COVID infection that might affect many of us in our practices. And this is called CRAB, which is a carbapenem resistant Acinetobacter, and he'll discuss all about why this is an important disease entity and what the implications are for our practice. And then we'll open it up for questions and answers. And then I don't have too many significant updates, so if we don't get to them during this hour, we'll just send you some written notes for this meeting that might have some of the updates that we wanted to share with you for this week. So with that, let me just introduce my good friend and colleague, Dr. Samir Al-Saghbini. He's an infectious disease specialist. He works with us at Public Health. He also works in private practice as an infectious disease clinician. We're so lucky to have his perspectives and his expertise. And I know that he's going to teach us all a lot about this infection and ways that we can protect our patients. Thank you.
Sounds good. Thank you, Dr. Vohra. Okay, so let me share my screen first. Okay, so good afternoon, everyone. I'll be having lots of slides about the CRAB, so I hope by the end of this presentation, everybody has at least some idea about the CRAB. Most of us probably never heard of this new term for resistant bacteria. We're probably all familiar with the old boring stuff, MRSA, VRE, ESBL, but this is the new kid on the block. So these terms that you probably heard about over the last several months, and probably going to hear more and more over the next few months or several years to come. It's so just to give you some idea, when you hear the word MDRO, multi-drug resistant organisms, CPO stands for Carbapenemase, which is the enzyme that kills the carbapenem antibiotic, Carbapenemase producing organisms. And all these fancy three-letter, you see sometimes on a blood test or a culture and so forth, KBC, VIM, which I will go in details on next slides. They stand for the Carbapenemase enzymes, that part of this presentation for the CRAB. And then, so the CR when you hear CR, CRAB, CR stands mainly for Carbapenemase or carbapenem resistant, and the E, the A and B, and the P and A just this. So the E stands for the enterics, E. coli, Klebsiella, Enterobacter. The A and P is Pseudomonas aeruginosa, and the PA is the PA is the Pseudomonas aeruginosa. The AB is the Acinetobacter baumannii, the one we're going to talk about today. And the probably you hear sometime in the news, we don't have that yet in Fresno, but very likely we're going to have it down the road, the Candida auris, which is kind of a fungus that's multi-drug resistant. So how did we come to this stage with all these fancy multi-drug organisms? It all comes to the antibiotic resistance. You know, from my perspective, antibiotic was probably one of the best, if not the best, innovation in human history. That the invention of the penicillin and the sulfa drugs in early 20th century was by far something that written in the books as the best invention ever created. However, this same innovation is probably lead us to this big the swing into the other side, where you're dealing with a pandemic of antibiotic resistance and emerging resistant pathogens that we invented these antibiotics to kill it to start with. And if you read history over the years, since from the infectious disease perspective, Anytime you come with a new antibiotic, it doesn't take long until you start having these organisms that were sensitive and susceptible to this particular class of antibiotic to become resistant. And this tends similar to the COVID concept, where a virus could spread globally. Bacteria tends to follow the same at a smaller, slower pace. So why do we have antibiotic resistance? By far, the most common cause is overprescribing antibiotic. As you know, you go to a third world country, Mexico, India, Syria, antibiotics are over the counter. You don't need a physician to write prescription. You could just feel you have a sore throat, you go to the pharmacy, you get your amoxicillin. In the United States, we do have that supervision where a physician needs to write it, but as most of you know, myself included, many times we overprescribe antibiotic. It gives us a peace of mind. If you have a family member who brings the child for a cold, it would be easier for me and for the mother to be satisfied with antibiotic prescription for common cold. That happens frequently in the outpatient setting. In the hospital setting, sick patients in the ICU, hard to tell if they have bacterial or viral infection, we throw antibiotics left and right. So overuse of antibiotic over time leads to trouble. The other kind is the opposite extreme, where we're under-prescribing antibiotic, or we're prescribing antibiotic and the patient does not take it. One big example from personal experience is tuberculosis. If you have a condition or an infection that requires multiple antibiotics for a long duration of time, you're going to have a significant number of patients not taking it, especially if you're dealing, let's see, with a latent infection requiring several months of treatment. So overprescribing, underprescribing kind of lead to these bacteria just gaining strength and immunity to these antibiotics. And comes the other portion of this story with resistance, mainly having the agricultural use of antibiotic that has been a big problem lately, and dealing with these people who had, or these patients who had multi-drug organisms, dealing with their infection control, which has been a problem, as you know, with COVID, but it's a bigger problem for longer duration of time with these bacteria. So in the 1930s was the sulfa antibiotics were the first antibiotics used in common practice. So in the 1930s, it didn't take much before you start having necrotizing infection that's resistant to sulfa drugs. So all these military hospitals during war, wound infections and so forth, people were treated with sulfa, and then many of them died simply because the strain, the group A strep, that was simply very resistant to the sulfa just shortly after it was invented. Penicillin, which considered 1926 when Fleming invented the penicillin, which was by far a revolutionary, something that happened in history. And then we didn't start using penicillin until the early 1940s. And Staphylococcus aureus, just it didn't take more than a year or so until you start having strains with resistant bacteria. 1961 was the first identification of MRSA. So now MRSA becomes a normal thing in our daily life in a hospital or before surgeries and so forth for colonization, and who should be screened and not. But this has been there for several decades. And this started in the same story, methicillin, a synthetic antibiotic. 2 years later, you identify the first MRSA strain. 1966, we start seeing the VRSA. Probably not many of you are familiar with the VRSA, but we see vancomycin resistant as the MRSA that became resistant to VRSA. And this was just 30 years from the MRSA emergence. Gram-negative rods has been kind of late into this game of emerging resistance. So 1996 was the first KPC, which is the Carbapenemase produced by the Klebsiella pneumoniae, was the first year identified in the United States. 2007, multiple reports, especially from Eastern Europe and South Africa, about XDR TB, where you have simply no medication to treat tuberculosis infections. And again, TB, although not something endemic here in the United States, but just for you who do not know the burden of TB in the world, third of the population have TB infection, 30%. And that's why we screen for latent TB. But the more you have resistant strains floating around, you're going to have these cases where latent and then active TB that's really resistant to the first line drugs. 2008 was the first superpower, if you want to call it, Carbapenemase, the NDM, which is the one we're dealing now with big outbreaks in the county and nationwide. So the New Delhi metallo-beta-lactamase was identified in India in 2008. It was a Swedish hospital. The patient was in New Delhi. It's speculated now that 80% of the population of India carry the beta-lactamase NDM. Scary numbers. 2013 was the first CDC report. If you follow the CDC reports, the MMR was the one that has a high alert of the three pathogens that consider at the time to be an emergent pathogens, mainly C. diff, Neisseria gonorrhea that was resistant to cephalosporins, and the KPC, Klebsiella pneumoniae infection. 2016, we start seeing the MCR gene. This is a plasmid floater that conveyed the resistance to colistin, which is an old antibiotic that's used, you could say, a last resort antibiotic. 2016, the first case of Candida auris, which is a candida or a fungus that's resistant to the regular antifungal that we treat with. And this has been a problem in the southern part of the state. I will show you some slides later. 2020, the CRAB. At the end of 2020, with the COVID, cases start erupting in California. Of course, this report from the CDC was starting from July in New Jersey, but it didn't take that long before it starts spreading west. So what's the difference between these probably, most of you probably find this boring stuff. For me, this is my bread and butter. So gram positive, gram negative. You hear this all the time. Probably if you are a general surgeon or a neurologist, or probably you don't care about the stuff unless you have a patient and you're dealing with an infection and you're looking for the gram stain. So the gram comes from the Hans Christian Gram. He was a Danish scientist who did analysis in the morgue in Berlin, in Germany. So for several years, he will look for people who died from infection, take specimen from the corpses and look under the microscope. He invented the special way of staining, and he could tell, he divided the bacteria between the gram positive, which turns purple with these 3 steps of gram staining, certain colors that he applies to the bacteria. And based on the component of the cell wall of the bacteria, you will have a purple color and you have a red color. So gram positive, gram negative. And it just, I find it funny when he published his findings back then, he felt that this was imperfect way of identifying bacteria. But nevertheless, look, we're almost 120 years later. This kind of still our standard of care, right? To identify Staph aureus, to identify E. coli. So the gram negatives, gram positive, as you know, the main 2 big guys, the Staph species and the Streptococcus. Gram negatives, they have much wide variety of pathogens. You have to keep in mind, many of these bacteria that we do have will live as best friends. You know, if you take just a random 100 people walking in the street and you swab them, you will find probably 40 to 50% carrying the Staph aureus in their skin or in their nares. If you take childbearing females, you're going to have 30 to 40% carrying group B strep. One reason why we screen pregnant females for group B strep. Many people, males and females, they carry group B strep in their digestive system and the upper respiratory tract. This is a little bit different for gram-negative pathogens. Not all gram-negatives are co-inhabitant of the human body, where we live in harmony until something happens. If you look at the gram-negatives, you do have the big group, which is the enterics. And these are mainly what we call it the GI flora. Many probably will GI flora. We know it from C. diff, we know it from probiotic and so forth. But what's GI flora? So these strains of bacteria, E. coli, Enterobacter, Citrobacter, we carry these normally in our digestive system. We don't get sick from it unless something happens. It goes to your urinary tract, you got UTI, you had a trauma, you get bacteremia, etc. But we do have the others. These are environmental gram-negatives. And the big organisms, Pseudomonas aeruginosa and Acinetobacter species. So these are not co-inhabitant of the digestive system. They are not colonizers in a normal fashion. They're mainly present in the environment. And if you got exposed to them, you could carry them and you could end up getting infected with them. So how bacteria become or fungus become resistant to the antibiotic? There are 5 main, I don't want to bore you with this, but you heard this in medical school and it's probably not very interesting, but with the COVID, I'm sure many of you probably now are much more curious about the genome and the DNA and the structure, but bacteria is no stranger to this mechanisms. You have an antibiotic that comes in, the 5 mechanism, either you don't let it in, or if it goes in, you kick it out, or you have a genetic transformation for the target of the antibiotic to be altered, or you have an enzyme that will hydrolyze it and kill it, or you will change the target in the cell wall. They call it penicillin binding protein. And the problem, the bacteria doesn't become just resistant. So it becomes resistant and it gives this new resistant mechanism, or the gene that became in, that have that code for resistance, it gives it to other bacteria. So bacteria is different from viruses. Viruses, as you know, they're incomplete, imperfect organisms. They do need another cell to multiply, to survive. A virus cannot live on its own. Bacteria can. Bacteria has the mechanism, the ribosomes, the protein machinery, and so forth to produce and survive. But bacteria, on the other hand, has this floating organism. What's the difference between prokaryote and eukaryote is a human cell has a nucleus inside that has a nucleus membrane that protects the coding material, the DNA, from the plasma component, separated. Bacteria does not have that. So your DNA chromosomal structure is floating in the plasma, and part of it is just what we call it the plasmid. It's another piece of the DNA that's separate from the main mother structure of the DNA, is floating around in the plasma. And the minute you're going to have a coding alteration, a mutation, because of that antibiotic that was exposed to this organism was exposed to, this coding material could be transmitted from this bacteria to other bacteria in 3 different organisms. It could be a virus, a COVID virus could come and move this resistant material from this E. coli and infect another person, and with that infection, it brings this plasmid with it. This is what they call it, the transduction. And you have the conjugation, where a bacteria will come in a physical contact with another bacteria, and a transfer of this material could happen, conjugation. And the most important one is the transformation, where you're killing an E. coli UTI that was resistant to multiple organisms. Guess what? This dead or live bacteria could move its genetic material to another bacteria. It could be E. coli, it could be Acinetobacter, it could be Staph aureus, that host has it. And this material could be transferred to the other organism, regardless if it's the same or different one. Transformation became the biggest challenge with these multi-drug organisms. And with that, the minute you're gonna have a resistant organism somewhere, humans are social animals, right? We travel, we cruise, it's gonna spread. There's no limitation for the invisible organism to spread all over the place. To give you an idea, the difference between gram-positive and gram-negative is very significant when it comes to microscopic. Again, this is probably boring stuff that no interest to you, but a gram-positive organisms, they do have this solid material, which is a combination of protein and carbohydrate. It's called peptidoglycan. And this mainly is the cell wall that protects the Staph aureus and all these organisms. Gram-negatives, they do have that same material, but it's like plywood in your house wall. So it's a small piece that kind of in between these two layers of the cell membrane. And in between, this is what they call it, the pericytoplasmic space. This is where the penicillin binding protein resides. So this is where also this space in between the two layers will have these Carbapenemase reside. So make it in a lay language that gram-negative organisms, they tend to be stickier because of the structure of the cell wall. They are much different organism from gram-positive organisms. Quickly about the beta-lactam antibiotic. Why do we call it beta-lactam? This is the structure of the beta-lactam. It's mainly 4 atomic structure. It has a carbon. The minute you cannot replace one of the carbon by a nitrogen, it's called a beta-lactam ring. So there's beta-lactam, which is 4. There's alpha-lactam, which is 3. There's gamma, and so forth. So all the antibiotics that not all of them, but the major class of the antibiotic, it has this structure in it. It could be penicillin, it could be cephalosporin, it could be carbapenems. And this structure has been there. There have been no new classes of antibiotic for the last 40 years. And this is where we struggle with this the beta-lactam, that if you look at the beta-lactams antibiotic, there are mainly 4 different classes. Each one of these classes also, you're probably familiar with, it goes in different generations. Cephalosporins come in 1st, 2nd, and 5th generation. Same thing with the penicillin. So again, this is a structure of the gram-negative organisms. You have 2 layers of the membrane. In between, you have the peptidoglycan, and you have the space in between these 2 layers where the beta-lactamase, these are the enzymes that produced through the genetic material, and it comes in here. It's like a police waiting for any antibiotic. The antibiotic will come to this penicillin binding protein, which is the inner part of the cell membrane. And the antibiotic will be binding here. And from here, it will disrupt the cell membrane, kill the bacteria. But these carbapenemase, they will be floating around, just waiting for any penicillin or cephalosporin to come in, and will bind it and deactivate it. That's similar to what we talk about, that so gram-negatives in particular, the beta-lactamase, these are again the enzymes that floating into the cell wall, watching for any new antibiotic that has been maybe produced or introduced to the bacteria before and deactivate. Just quickly about the difference between bacteria and humans. For you and me to transfer our genetic material, it goes mainly vertically. Right? You pass it from the dad and the mom. Half of the gene comes from the dad, half from the mom, and they go make a baby. Here, it's looking different. Your genetic material will be transferred horizontally. So bacteria will transfer the genetic without the vertical transmission. It just gives it to its neighbor. And again, this comes in the 3 different mechanisms. It's much more powerful way of survival compared to having the traditional way of having offerings and vertical transformation, where half of the genetic material comes from one parent, compared to here where you transfer most of the important one for survival, transfer it to co-inhabitant of the host. This is kind of the same. The plasmid, the one we talk about, the genetic floater, and the cytoplasma could be transferred to another organism that has no, let's see, in our discussion here about antibiotic resistance, either transferred by a physical canal between the two, or simply just, this could be moving, bacteria dies, it could just, or not, it could just move around without physical contact, the transformation, and moves to the other bacteria. And all these bacteriophages, the one that the viruses, how they could become the new thing now for either cancer treatment or vaccination, it's kind of the same principle. Mainly you're having a virus carrying certain genetic material and moving it between different cells. And here we're looking mainly for bacteria. Again, the carbapenemase deactivates any antibiotic before the antibiotic comes to the cell and deactivates it. The beta-lactamase it acts by simply disrupting this anatomy of the ring, and from there it becomes an active chemical structure. How do we test for antibiotic susceptibility? When you look at any susceptibility or sensitivity or a drug, DST, drug susceptibility panel, mainly it's a phenotypic, meaning a microbiologist, if you've been in the microbiology lab in your hospital, or it's too much work. You're taking a bacteria, you allow it to grow, you have the colonies, and you start putting these antibiotics, and you look around to see if there's any zone of clearance. And based on that, you will say, hey, it's sensitive, your strep is sensitive to penicillin. So this still has been the traditional way of conducting susceptibility, mainly culture-based material. And then we come to the beta-lactamase. So if you look at this structure here, mainly to tell you in history, how did we end up with the beta-lactamase enzymes? So again, beta-lactamase are mainly designed to deactivate the beta-lactam antibiotic. As I showed in the previous one, over the years, you start having more and more. The minute you're going to have new antibiotic, when we start having cephalosporins, 2nd and 3rd generations, we're starting seeing these extended spectrum cephalosporins, ESBL. You will have E. coli that's resistant to cephalosporin, to Rocephin, ceftriaxone. This is ESBL. With more extended spectrum, where it was limited mainly to cephalosporin, we now start seeing more carbapenemase, which is more beta-lactamase that's more resistant to the new generation of antibiotic. And if you look at the TM1, this was initially reported in Greece, a child by the name of Tomanera. So TM was mainly started in Eastern Europe, overuse of antibiotic. From there, it didn't take long before it spread to other countries. And from there, this was the beginning of the ESBL for cephalosporin. It was first generation, cefazolin and so forth, resistant to it. And it didn't take much long, 2 decades, to start seeing other cephalosporin also with resistance. Carbapenemase. So the carbapenemase are the new most powerful carbapenemase in the universe so far. They're mainly not just active against penicillin or against cephalosporins, but they're active against the carbapenems. The carbapenems, mainly, these are the most powerful last resort antibiotics. And as I said, the KBC, the Klebsiella pneumonia carbapenemase, we start seeing this in USA in 1996. And now the big metallic carbapenemase, the IMP. You're gonna see these probably once in a while, or you hear about it somewhere in a medical report, but IMP, most of these, if you look at the history, they started with other countries. So the IMP started in Japan, the VIM, they are named after that location where it was started, Verona, Italy, the NDM, New Delhi, and the OXA has been there. This is related to the oxacillin, has been there for some time, since 2003. So these are mainly the big five. If you look at the Carbapenemase testing that we do now, it tests mostly for these big five. Beta-lactamase, there are mainly two different kinds. We all the time now with these outbreaks will be concerned about the metallo-beta-lactamase. And the difference between the metallo, these are heavy mineral, it's a zinc compared to the serine. So this branch here, the metallo, it gives you these, the M1s, the NDM, the IMP, the VIM, and these are hardcore carbapenemase, meaning it's easily transmitted. Most of these sometimes will lead to complete non-susceptible strains, meaning all the antibiotic tested by phenotypic analysis are resistant. And the serine beta-lactamase, the other classification A, B, A, C, and A and D, these are mainly the older one, the oxacillin, the AMPC, which is chromosomal anti-carbapenemase. These are not as bad as the metallo one. And now the current outbreak, it's mainly the NDM, New Delhi metallic carbapenemase that's floating around. Again, this is similar to the with Acinetobacter, similar to the other ones, that you do have these carbapenemase floating around between the two sides of the cell membrane, waiting for any penicillin or carbapenem antibiotic to come and be deactivated. So Acinetobacter, we'll talk more about Acinetobacter. Acinetobacter, if you have it, you're in trouble. Not everybody who had Acinetobacter will be in trouble, but if you have these different multi-drug organisms, and you choose between, let's see, MRSA or Acinetobacter, the mortality for you to die from Acinetobacter if you got colonized is much higher than any other organisms. And part of the problem here, you do have literally no antibiotic in clinical trials for a long time. Again, if the last antibiotic we had was 4 decades ago for a new novel antibiotic, that tells you some of the bigger story that we're struggling with this. Most of the time, there's no incentives for a big pharmaceutical company to make new antibiotic. You don't make much money from antibiotic compared to make a new cancer or no vaccine, for example. Most of these antibiotics are overused. Any new antibiotic gonna come to the market, gonna become generic. So the antibiotic you're dealing with, the one I deal with TB, for example, I mean, they're still there since the 1950s. Thank goodness, still working, but bacteria, it's a little bit much more complicated to make a new antibiotic. So Acinetobacter is different from any other organism, especially if you're talking about gram-negative rods. Acinetobacter could survive, it's again ubiquitous in the environment. It could survive on a service for weeks. You're having a patient that you didn't know if they have Acinetobacter, the patient leaves the room, that services that the patient was in your hospital or in your clinic, guess what? You have Acinetobacter there. And the next patient who comes in, if you are not cleaning the room the right way, there potentially could be transmitted. Acinetobacter could make a biofilm. What's a biofilm? Is this gel material that if you're having a central line, a catheter in your bladder, a hardware in your back, and you get infected, all these bacteria will love to make this gummy material around it to protect it. It becomes like more a castle. Acinetobacter doesn't need really, it could make this on any surface in the environment. It's a very resistant bacteria. The polycarbonate that used in most of these plastic material we use in the hospital and so forth, these are just perfect material for these biofilms to be generated. And from there, it will be just the minute you're gonna have Acinetobacter in your facility, it's gonna be an endless headache because it's gonna be requiring too much work to clean, to make sure that the patient is isolated and so forth. And Acinetobacter for a long time has been known to produce the OXA, Carbapenemase. So Carbapenemase has been intrinsically linked to Acinetobacter. The new thing now with these outbreaks that we're dealing with Acinetobacter that's producing these new metallic beta-lactamase that never been known to produce them. And again, here comes the same, from my perspective, I think it's fascinating when you have a patient, and I see some of these patients myself. You have Mrs. Smith, who's, let's see, comes into the hospital, never been in the hospital, never been exposed to antibiotic. And she had, let's see, a CRE in her urine. And you scratch your head, you say, how did she get CRE? If she never been exposed to repeated courses of antibiotic, if she never been exposed to a husband or somebody at the house with these resistant pathogens. And here's the trick that, as I mentioned, you could have a bacteria, an E. coli that has resistance. This E. coli could move that genetic material to another bacteria, not E. coli. It could be Klebsiella, it could be Staph. That genetic material could float between bacteria strains, not necessarily the same. And that bacteria could float to another host that was an innocent bystander. Mrs. Smith comes to this room 208, for example. A patient was there with Acinetobacter. You didn't isolate the patient. You didn't clean the room after the patient was discharged to SNP. There's a chance that that patient, the newcomer to that room, will be infected, will carry that genetic. It's not, I'm not like the king of doom here, but it's, again, not every patient, this is not COVID, like you can have 100%. But we see more and more of these folks who never been exposed to resistant to high core antibiotic. And now they have the same. And the same story happened with the Acinetobacter. Acinetobacter never been NDM producing organism. And now suddenly it's all over the place. And that could be related to an organism unrelated to the Acinetobacter has been infected with it. So the CDC, as you know, had these 5 big branches for the urgent threats. And by all means, CRAB stands on the top of that. I think in a previous lecture, we talked about the drug-resistant research. From my perspective, it's a bigger threat in the sense it's much more in the community. There's no really kind of measures to prevent this, although it's limited to certain people. But all the other organisms are more hospital-acquired organisms, healthcare setting organisms that without vigilant and kind of detailed infection control measures, they will spread. So Acinetobacter CRAB, Candida auris, C. diff, and the CREs. This is a little bit older slide from the CDC, but CRAB is a costly, the newest one, actually $1.2 billion spent. I don't know what year, if it's the last year of 2019. So most of these numbers you have here, they're a little bit older and probably double or triple. Acinetobacter, again, is the CRAB is simply the bacteria is resistant to the carbapenem antibiotic class, so carbapenem resistant. The CP is carbapenemase resistant. Carbapenemase producing CRAB is mainly, it's resistant by producing the carbapenemase. Just if you're curious about the number, the name, this was initially isolated in 1911 from environment. Acinetobacter stands for Acinetobacter, which meaning non-motile. It doesn't move like E. coli, but also it's very sticky. Acinetobacter meaning it's the non-motile bacteria. And the Boehmanii is after, like most of these bacteria are named after the scientist who identified it first. So another European scientist, Boehmanii or Bowman. It has been, again, this is mainly environmental, healthcare setting organisms. And Acinetobacter has been, it's not all the time, has been a hospital-acquired infection. For a long time, we, just to give you some ideas, all these natural disasters, any environmental pathogen, it tends to give outbreaks or infections during natural disasters. You go for a tsunami, a war zone, you kind of have these Acinetobacter. One of the theory that why Acinetobacter spread was mainly during the Iraqi and the Afghan war, where you have lots of wound infections. People got exposed, especially in Iraq, where most of the soldiers with these wound infections, they have been floating between multiple local and then international care units or hospitals. And several of those folks had the Acinetobacter, multiple antibiotics, either acquired from that country or not, and then spread all over, different infection control measures and so forth. So most of the time, any war will lead to these environmentally present pathogens to spread. And with that spread leads to more colonization and antibiotic resistance. So these are mainly much more into the natural disaster, as I said, climate, weather, like subtropical areas. Acinetobacter will love to be a problem there. And now we see it more by looking at these numbers, roughly much probably prevalent now, but all these, I'm sure in any hospital setting, you're gonna have, if you look at your records, you can have Acinetobacter isolated somewhere in a blood or a wound or a urine culture. And the typical patients that we see in our daily life now is mainly these hospitalized patients, long hospital stay, multiple tubes, mainly the patients we are seeing in Fresno are these typical patients at this slide. And the Candida auris is similar. It follows the same pattern that CRAB. This is mainly, as I said, Candida auris is a candida that's resistant to most of these antifungals. The typical clients of any facility will be mainly ventilated SNFs. These are subacute rehabs. These are the patients that you see most of these organisms growing there. It's just a perfect setting for these bacteria to grow, right? If you're having a SNF where everybody with a Foley and every week you got a urine culture because the patient is a little bit obtended and you start giving him nitrofurantoin and zithromycin and so forth on a weekly basis. These are the patients, they just simply harbor these organisms and the same bacteria. It's just amazing when you see, let's see the patient who had Klebsiella, which was pan sensitive in June, and comes December and suddenly this organism is pan resistant. Unfortunately, and I hate to say this, part of the problem is how our clinical practice. I understand, like in a long-term facility, it's hard for you to tell who has it and who doesn't have it and who's colonized and who's infected. But overuse of antibiotic in these kind of patients becomes a big problem. We don't have that much in Fresno compared to going to, let's see, bigger counties where they do have trauma centers and burn units and spine rehab programs where everybody with neurological problem and multiple tubes. But you could, as you see with the slide, SNF patients who are walking around and independent and who are there for physical therapy for a month or so probably have lower risk compared to somebody who is long-term in long-term facility. And comes the bigger question again, what's a colonization and what's an infection? When do I treat and when should I not treat? Most of these, at one point, you kind of reach a point of time where that easy solution where you give nitrofurantoin for this E. coli in the urine doesn't exist anymore. And you're scratching your head what you're gonna do. So yeah, as a general rule, isolating bacteria in a bodily fluid, especially in the setting of tubes and so forth, does not mean the patient is infected, does not mean the patient should be treated. Actually, you're doing more harmful action treating somebody who does not have a clinical evidence of an infection. The bacteria, the culture should not be obtained to start with. And you, if you obtain it, I think you should make your best clinical judgment not to use. Again, we do this probably, it's the easiest way for an emergency room doctor to see a patient, kick him out if the urine showed 2 white blood cells, to come out with antibiotics. Even if the patient doesn't have urinary symptoms. The same thing with a hospitalist, or if you're a family practitioner, we do it on a daily basis. And here comes the biggest thing about colonization. And what does colonization mean? Meaning you have these organisms, these crabs, we see it in the rectal swabs, we see it in the axillary swabs, in the skin swabs. When it's there, there's no way to get it out. And if you work in a hospital setting and you come to this patient's room, I used to work as a hospitalist and I take it for granted most of the time. You go in the room, you're busy, you're having 20 patients to see, don't have really time to look at the sign and what needs to be done. Should I wash my hands? Should not? But that patient who's in the room in contact isolation, everything in that room probably is infected. And the physical therapist, the caregiver who comes in and out without having gowns or washing hands, you are looking for trouble. This thing gonna just move around, subclinical silent transmission. Same thing with your equipment. A patient with these MDRs you should not use your stethoscope, should not use your thermometer for this patient and go to the next patient to use it without cleaning. COVID did teach us something, right? With COVID comes this big tide of these organisms that you see it now, and we're going to see it more down the road. And different things led to the emerging, appearance of these organisms. PPE has been short, overwhelming staff, crowded rooms, and so forth. So this was a perfect environment for these organisms to spread. And this is just to show you, we have, although this is not a local picture, this came from Chicago, their Department of Health. But this is what exactly we see here. A patient comes in with, let's see, this is for Candida auris. This patient comes in here in this room, and this was in March of 2017. It didn't take long. Of course, body testing was not very aggressive. It comes a few months later, and boom, you're having almost a third of your patients infected with the Candida auris. It didn't take much. And then now you start seeing, when you start testing for other organisms, the whole thing came in one package. You have Candida auris, you have CRAB, you have CRE. So a big party. And the minute you're going to have one of these organisms, you can bet 100% that you probably have some other organisms that was not detected there. And what about the numbers? So if you look at in California, this is a little bit older slide, but in California, the number of carbapenem resistant organism in California has been shifting again to the Acinetobacter. You see 43% compared to 13 and 3%. The same thing in the United States. If you look how much of these carbapenem resistant organisms are producing the carbapenemase, which becomes again much more contagious. It's a scary number. 15 to 90% of the Acinetobacter are carbapenemase producing, compared to let's see, just very low numbers. So Acinetobacter compared to the CRE or the CRPA are much more contagious because they tend to harbor the carbapenemase, which becomes more infectious. This is much more recent. So between 2018 to 20, over 2 years in California, look at these numbers also. If you look at the number of the CRAB in California, that was carbapenemase producing. As I said, OXA usually are the typical we see with Acinetobacter, but you do have about a third of them. They do have the NDM, the notorious one. This was up to 2020. Well, now it's a much different story. So in this year, look at this slide. It's a very crowded one, but I want to show you that the non-susceptible strains, meaning you're having a carbapenemase producing CRAB, 33% of those are non-susceptible, pan-non-susceptible, meaning aminoglycoside, carbapenemase. You look at the sensitivity and it's completely immune to all the antibiotics available. You have to go for some fancy new generation of carbapenem with the carbapenemase inhibitor. So a third of these are mainly resistant to everything. And although this was from rectal swab, these people probably were just done as a contact investigator, contact tracing method. But these patients, if they got infected and sick from that, they're probably going to die. If you look at the numbers here, SNF versus ventilator SNFs, a majority of these patients, they're mainly in some big portion of them in SNF. So this is also a new concern, that this has not been just limited to the ventilated folks. It has been moving to regular ambulatory patients. And then here comes the by counties. And it's just unfortunate that the counties are getting hit by this are the inner, the valley counties. So Stockton, Modesto, Fresno, just following. Look at Stockton area. I mean, it's just amazing. It just has the majority of these patients. Fresno here, these are old numbers. So now we're up to 15 as of last week. I mean, you wonder why the bigger counties are not getting affected. I mean, excluding Santa Clara and San Diego, they have just random small cases. This is mainly the Central Valley of California that's getting hit with these new strains. These up to July, you could see this is the Candida auris. Again, Candida auris, we never had it in Fresno. It's much more Southern California. Big outbreaks. This is much nastier than CRAB because easier, you can't detect it and it's harder to treat. You look at the COVID cases and the CRAB and the Candida auris, it follows. It just, they come hand by hand. And the NDM Acinetobacter, again, you see here up to July, Fresno has been getting there. So since our first case, like sometime in the summer, and we start just building up. The whole thing started in December of last year, and boom, cases are on the rise. Again, the main concern that you do have more of these NDM Acinetobacter in the skilled nursing facility rather than in the ventilator facility. In Fresno, we're up to 15. Mainly in the ventilated subunit. We have two, as you know, acute, subacute rehab in Fresno. One of them has been impacted for the last several months with the OXA-23. One actually is probably going to lead to outbreak very soon, and the other one, as of yesterday. And we do have 2 SNFs there. Some of these residents has been in different hospitals. There have been exposures here and there. And you could see most of these folks, although they're younger, but I mean, the age doesn't tell you the whole story. Most of these patients are with multiple medical problems. And through contact tracing, multiple contacts has been there. And many of these higher risk exposures, roommates or sharing the same bathroom and so forth, turn to be positive with further screening. So what do we do? And you know, this is all just something that we have to work all together, because this is not something that you could fix in your hospital or I could fix by just telling you what to do. Number one is just mainly when you test for Carbapenemase. Anytime you have any strain that shows carbapenem resistant on the culture, please isolate the patient and let us know. It's important for your facility. Most of the big hospitals in town, they're able to do the Carbapenemase. If you can't do it, let us know. We could help you with doing it. And even if the Carbapenemase comes back negative, and this is a story from yesterday, actually, a very smart infection control at CRMC, you know, she looked at this, and this patient had from the trach, had you could see it's CR CRAB resistant to monoclonal carbapenem antibiotic. She tested it through the lab at community. Everything comes back negative. But then she realized that, you know, the Carbapenemase testing they do in the hospital doesn't detect all. It detects only the 5 kinds, but not all of them are detected by the CFIAD assay used in the hospital, which is usually the Quest have and so forth. So she alerted that this is similar to the strains that you're dealing with the other subacute, and this patient is to be tested for the other Carbapenemase. So any carbapenem resistant organisms, please let us know, because this patient probably had Carbapenemase that needed to be tested either by your lab or through the public health lab. As you know, it's a big package of things need to be done. Anytime you go and see the patient, it's important for you to wash your hands, other boring stuff that we all taught to use it, and we hear about it every day, especially with COVID. And it's important not just to wash your hands, quality of you wash your hand, it's pretty critical. This is a contact precautions, so gown and gloves, it's very critical. And it's not just having the gloves in, you have to wash your hands after any contact with the patient. Having accessible weight for these alcohol-based hand sanitizer, it's very critical. And cleaning and disinfection. It's like if you're having if you're gonna mop your floor, you know, if you're gonna, you have to sweep it first, right? So just doing your cleaning of the room after the patient leaves, by all means, is no adequate treatment. All these patients with these resistant organisms, they go to see their podiatrist, they go for hemodialysis. That room that has that patient with that resistant strain will need to be terminally cleaned, because you don't see it, it doesn't mean it's not there. It's very likely to be there. And the staff who are coming in and out of that room for that 2 or 3 hours until the patient comes back or the patient was discharged, very likely to be a vehicle to transmit this to others. Your bleach over there, it's important to see the dilution. I'm sure the infection control folks probably deal with this on a daily basis. You can't take your household bleach and just do it at the hospital setting. Yeah, this is not the household bleach that should be used for disinfection. And many times, I mean, cleaning, I think, becomes a critical part even with COVID, right? We learned that the hard way, that you could clean the room, but it comes all the time to the quality. You could have a sign to say that you need to have contact precaution, you had to wash your hand. Does people do this or not? So auditing, it's very critical for any infection control program in a facility or in a hospital, making sure your staff are doing it, not by forcing it. Most important critical part is education, that this is important for you to do it that way. And if you don't do it this time, do it the next time the right way. Having not complicated sign to tell you what to do. And cohorting. Most of these folks who were coming from a facility with outbreak should be in a private room. You should not cohort somebody with somebody else without knowing what pathogens they have. We see this, we struggle with this actually in some facilities, even dealing with outbreak. And it, you know, the minute you're gonna cohort somebody with a different pathogen, you're asking for this fire to spread. So cohorting should be when it comes to these organisms, according to the Carbapenemase. It doesn't matter if it's E. coli or CRAB or not. The minute you're going to have NDM, well, the enzyme is what's giving you the problem, and those patients should be cohorted together. And that's the same thing. Without cohorting, proper cohorting, you're looking for more and more cases in the facility. Again, with COVID, there have been struggle with everything, but I mean, hopefully this has led to more, I think, learning. And now I look at the infection control staff. It's probably the most important, or one of the most important, I think, component of any hospital or any care facility, because infection preventionists have been and will be down the road the most important part to prevent spreading. Having these resistant bugs are not good for the patient itself. I mean, it's, I think, the way to build more, you know, all the CMS, all the surveys, it all depends, even core measures in the hospital setting. It's all depending on how much of these infections you're going to have in a particular part of the year. So the most important thing, the way I see it with these, is mainly communication. These patients, they go, especially the ones with, well, multiple medical problems, they go from different facilities. We see it now much more coming from either nearby counties where people or patients move from hospital in Modesto, they come to a rehab in Fresno, they end up going to community, to Kaiser, to St. Agnes for different things. And if you do your best with everything you do in the facility, when the patient is there, this is definitely not a good way of preventing this, because if you don't communicate that this patient needs to be in isolation, or if this patient is coming from a facility where it needs to be, the patient needs to be screened because the facility is dealing with outbreak, it's going to lead to spread, not just in the facility, but in the SNF next day. So it's important for any infection controller staff to put this patient in isolation, to flag the chart, to tell the facility, accepting facility, that he is exposed or infected or colonized with the MDR, so they could take the proper precautions. And this becomes like any other things. It becomes an endless vicious cycle, spreading infections between different places. We'll skip this for the sake of time. There's this form that most of you are probably aware. All these facilities dealing with outbreaks locally or regionally, every 2 weeks, the list of these facilities are given to the infection control and staff and all the facilities locally. So at least if a patient comes from this particular facility that has outbreak, at least the hospital or the facility know what to expect and how to isolate. And when it comes to screening, which has been a challenge because of the overwhelming limited options there, please let us know. If you have a patient who turns to be Carbapenemase producing, it's something that you should do by CMR. You should just call the number also 3332 just to let us know how to screen and where to send the specimen. These will be provided to you also on the slides. I will not go over them, but most of the infection control measures, the folks with infection control in this call, I mean, they know that there's also FCDPH has this honor roll for silver and cold and so forth. So I think it depends on how many of these healthcare associated infections you have and these MDRs. The key message in general that these MDR, CRAB is one of them, are on the rise, and mainly they're health setting pathogens. They infect mainly the sickest of the sick. They don't infect your staff. They don't infect somebody who's, but potentially could, these patients or these staff could become a vehicle to transmit it in that setting if they don't follow the certain things for infection control. Public health, in addition to the infection control, are very important way to stop this cycle. Dealing with a patient in a facility, but on isolation, it's good and sound, but more important than that is to prevent the patient next door from getting infected, either by not having a perfect infection control measures or by not letting an accepting facility know that this patient has been exposed and will need to be tested. And the health alert, I think recently that you probably have a copy of, does tell you who to call and what to do and the precautions needed. My last slide is mainly this. This is a collaborative effort. It doesn't happen by one person or one hospital or one SNF. It needs communication is the key to stop the rise of the CRAB and the MDR. And I'm open for questions.
Thanks, Dr. Al. That was great. We'll look at the chat. I think there's a request for these slides, so hopefully we can share the slides out with everyone to review. And we'll share the health alert that we sent out previously as well. So, you mentioned public health having a real crucial role in tracking these. So I'm sorry, just for everyone's information, I mean, so is that like an active list that's being kept at the state level or at the local level? And what happens whenever these patients transfer across county lines? Because it sounds like that's what's happening.
Yeah, so all these facilities, there are a handful of them, mainly in the Central Valley located. All these facilities deal with outbreak. And when I say outbreak, it's not like COVID outbreak where it might be just 2 or 3 weeks and it will go away. Mm-hmm. These outbreaks has been there for like months, including our 2 facilities. So any patient who comes from this facility who's dealing with outbreak, these facilities will be given to mainly Ondina here in Fresno County, where she distributes this list to all the infection control in the hospital and in the SNFs to know about these facilities locally and regionally, that these facilities are dealing with outbreak. Any patient, you're accepting a patient from this particular facility for rehab or for acute care, this patient will need to be isolated, regardless, again, if they're infected or not. Infected, of course, you should isolate them. So in addition to the public health alerting or sending this list every 2 weeks, the facility that deal with outbreak has the obligation to alert the accepting facility, a hospital or SNF, that we're dealing with outbreak, and this patient should be isolated and should be screened or swabbed. So yeah, there are two components, public health and of course the facility dealing with the outbreak.
There's a question in the chat. Do we have a protocol how we should monitor the unit, including the staff? So is this something where you have to check the staff for?
No, yeah, testing. I think one of the slides I showed you earlier that, staff, testing the staff never, it has very low yield of positive staff, meaning if I test the nurses, it's not like COVID, everybody got infected. So if you're having a case in your facility with CRE or CRAB, as I said, please let us know. These should be sent anyhow by CMR. You could call the number 600-3332, and we'll give you definitely guidance and what to do and who to screen and infection control and so forth.
Great. I'm just adding that number to the chat. Any other questions or comments? This makes COVID look like a walk in the park.
One thing I'd like to add, Dr. Vohra, with the influenza cases, we start seeing rise suddenly. If you have any influenza positive cases from a hospital, please let us know. We would like to subtype it. Our lab now is open and we're able to subtype these influenza cases. I know we had a few from CRMC the other day, but if your local hospital has influenza positive A or B, please keep the specimen and send it to the public health lab for surveillance.
That's good to know. Sounds like it's already happening, huh?
Yep.
Okay. Well, I mean, those are the comments that I was going to make, is that, with the Thanksgiving being next week, we do anticipate, unfortunately, that we will have increased transmission of the respiratory viruses, such as COVID, influenza, RSV, croup, and all of the other wintertime viruses that we tend to see. And so just be careful, tell your patients, especially your vulnerable patients, to take the precautions that they need to, whether that means masking, doing temperature and symptomatic screening so that they're not mingling with people that may be symptomatic and carrying viral infections, and of course, getting their vaccinations for COVID and influenza if they're eligible. That's what we're going to try to message about very aggressively tomorrow on our media, and hopefully you can help us by spreading that word through all of your communication networks with your staff as well as with your patient populations. And if you have any questions about any of that stuff, then let us know how we can help. And otherwise, we won't have a medical providers meeting next week, but we'll reconvene in the first week of December. So if there's no other questions for Dr. Al or in general, I think we will go ahead and adjourn. Thank you all so much for joining us today. And like I said, we'll share out these slides so that you can go back and review them and share them with your staff and with your infection prevention colleagues as well. Thank you so much. Thanks.
Yeah.
That was great.